Okay, so today I'd like to thank Ben for the opportunity to come and talk about our research and give you an update on small molecule inhibitors of the soluble epoxide hydrolase and nociception, which I'm sure this crowd is familiar with. Already? Okay. Let me shout. Okay, so nociception, that's pain signaling. And neuropathy and neuropathic pain are, when that's going wrong. And what I want to try and given the last speaker, try and give you more of an overview of is what we do. What my talk will be about today is what we do preclinically to demonstrate when we get a new small molecule, how that actually transfers all the way to becoming a drug therapy and a therapy for chronic pain. We have to go through years, basically, just to give you the real story, years of research and development, a lot of money, a lot of safety studies, a lot of applications and trial with the FDA and other organizations. But we're really happy to present here and let you know and update you on the progress that we've made. We've been funded by the Blueprint NIH Blueprint program, which will drive this into phase 1 and 2 clinical studies. So this is decades worth of research. This is the latest portions that we have on the pain work, and just to give you these updates. So who in the room has a science background? Okay. The rest of you have to remind me to keep you all along. I put on a bunch of the science slides because that's kind of my portion of the research is actually, I'm the scientist that does the preclinical research on the small molecules in animal models of pain, and provide the data on efficacy and the pharmacokinetics, like how it runs through the body, that provide the data that goes to the FDA to then get this approved for therapy, and then its first use in the phase 1 clinical trial in humans. So with that, the first thing I like to start off with is my acknowledgments, because they often get kind of squashed at the end. But to Dr. Hammock, of course, who couldn't be here today, but he is the CEO of Mycosis, a company I also work for. And we are developing the SDH inhibitors and small molecule therapeutics for chronic diabetic neuropathy specifically. We're funded by a number of institutes from the NIH. Most importantly, as I mentioned, the Blueprint program, which is actually allowing us to go to phase 1 clinical trial and up to phase 2. So, the science part of the chicken wire figures.
My voice is trailing off.
Okay. How's that? Thank you. Okay, so to give you a background on just where we are in using our small molecule is we are looking at lipids in the body, and our plasma membranes and all of the cells are made up of these lipids, and when we have an event like an injury or inflammation, then those are released, and they're acted on by enzymes. And I think a lot of people here might be familiar with the cyclooxygenase enzyme and inhibitors like Celebrex or NSAIDs like aspirin and ibuprofen that block that activity of cyclooxygenase. That blocks the prostaglandins then, and in not making that lipid mediator anymore, that's pain relieving. What we do is here in the middle, where there's other enzymes that then form epoxycosinotroic acids. A big name. I'm just going to say EATs, which is the EET there. These cytochrome P450 enzymes create this epoxygenated lipid mediator. Then our enzyme, the soluble epoxide hydrolase, breaks open into the vicinal dials down below, and those dials don't have any activity. So the biological activity that we're aiming at is that epoxide right here, and those lipid mediators that have been found in our next slide. When we inhibit that enzyme and increase these EATs, it's been shown to be antihypertensive, anti-inflammatory, and actually what I would say is analgesic, which is against pain. So that brings about another idea when you talk about these drugs, because I've already heard gabapentin mentioned in the crowd, but as we talk about diabetic neuropathy or neuropathic pain specifically, people will recognize that a lot of people have hypertension with diabetes. A lot of people have inflammation along with their pain syndromes, which then becomes a problem when we want to give drugs that you can't take with hypertension, like NSAIDs, right? So people can't can't have prolonged use of ibuprofen when they have hypertension. So these kind of things become problems. That also, if you consider that taking long-term aspirin will give you a GI ulcer, right? So we're looking at our technology being the way that the epoxy nitroic acids work is that they actually are antihypertensive, like I mentioned, and they actually don't cause those kind of problems with what is known to be a prostacyclin ratio issue of blocking COX enzyme that gives GI erosion. So we have some very good technology here, and it is offering really good analgesia. That said, I'd like to start off with a history which is kind of humorous, which is the first time we put the inhibitors in an animal, we got this flat line. And it turns out that this flat line is part of what I'm talking about, which is really fantastic, which means that they don't have any activity if there's no pain on board. We put this molecule into a normal animal, and it did nothing. Fantastic. We put it into an animal that had pain, and we see dose-dependent analgesia. So this is an inflammatory model of pain where we inject lipopolysaccharide, which is basically the outer membrane of a bacteria, into the animal. And it gives them an inflammatory cascade that we then treat with the soluble epoxide hydrolase inhibitors. And as you can see from the vehicle being 0 there, up to 10 mg/kg of the SEHI, we're able to actually treat the inflammatory pain in these animals. Then, this is a little complicated slide, but then we wanted to look at other models of pain that did not have inflammation as a background to see how widely we were treating pain and not just inflammation. And when we looked at other types of neuropathic pain, we chose diabetic neuropathy because it's actually a pretty good preclinical model to use. And what we found when we gave the animals diabetic neuropathy and left them untreated and they developed neuropathic pain was that compared to these drugs that we've been mentioning today, like gabapentin and pregabalin, that our SEHI, and this is now, when this says lead, that's our lead IND candidate that the company is pursuing, that at 300 times lower, 30 times lower the dose, we got the same efficacy in the diabetic neuropathic pain model. And this is, of course, in rats. We do this preclinically, we do this in our laboratory. As I mentioned, the rats have diabetes, it goes untreated, they get diabetic neuropathic pain, and we test that with similar tests that you've probably encountered as humans, which is a von Frey, where they pick your foot, and they ask you to see if that's painful, and they'll do it in different spots. We actually do that with animals, but with animals we actually have an anesthesiometer that's attached to it that can measure the grams force that they can withstand before they'll take their own paw away. So they don't tell us, but they withdraw their paw when they're uncomfortable, and we know the difference in grams that they've been able to take. So that's kind of a background on that graph. Moreover, then we went to the gold standard model, which is a surgery model. So the diabetic neuropathic pain is our indication, and we've shown that in our model of the human indication that we're going after. But moreover is that people want to see it in a model where it's due to surgery and there's no metabolism at the background of it, so it doesn't depend on the glucose level of the animal or their liver functioning and those kind of parameters. So we did it in a surgery model. So we actually surgically give the animals neuropathic pain, chronic neuropathic pain, and we call this a chronic constriction injury. It's a well-documented model from the 80s, and so it gets repeated, and it's the gold standard for preclinical work in drug therapies for chronic pain. And what we saw, again, is this is basically, if you look on the right, this is our dose escalation, and we see dose-dependent increases in the analgesia. So this is, just to orientate you to the graph, is that when there's a low baseline, that means that they're in pain. And then as we increase by giving increasing doses of the inhibitor, we see an increase in response. So we're getting dose-dependent analgesia in this model. And again, this is done with a similar von Frey test, which is actually checking the grams of pressure that the animals can withstand. And so it's then, as we noted before, gabapentin, I think this crowd better than anybody knows the side effects and the problems with gabapentin. For us, working with clinicians, it's also really a problem post-surgically when they want to send people home that are a little unsteady, and they give them gabapentin for pain control, and it causes even more dizziness, and then they get falls and further injury. So it's become, that kind of clinical problem, as well as people that, it has aberrant side effects that when you take it chronically is really unpleasant. But what we did is try to describe the differences between, again, so these are both of our lead IND candidate and our backup compound that we're developing for the company. And we try to describe the side effects of those in relationship to gabapentin and pregabalin. And what you see is that, yes, we do have a rotarod for a rodent, and it's like a little treadmill. And we check on whether or not they can perform, walking routinely over a certain amount of time without stumbling or falling. And as you can see with the gabapentin, as you would assume with the kind of dizziness that's reported in human patients, we see that in other mammals, and they're less likely to be able to perform to the maximum. We saw absolutely no change for, there's a little bit of, that's not a statistical change, but normal variance, but no changes for the use of the SEH inhibitors. Then we do too have a balance beam. It's called a balance beam. We look for foot slips that has actually a walkway. It's kind of like what we consider a catwalk for a rodent, a rat walk. And we look for foot slips, and actually another sign of dizziness is if the animal stops, and it can't continue. That's a sign that it's having some proprioception problems, and it's not able to go further. And as you can see with gabapentin, again, that's coming up. There's a lot of variability. So some animals perform a little better, but that's true for usually the human reports on using gabapentin. Some people are okay, some people are knocked out by it. So just as a indication that we're not seeing the kind of side effects and motor functioning scores that we are with the gabapentinoids. And then, as I mentioned, GI erosion. It's a huge problem with anybody taking NSAIDs long term. And what we're finding is really interesting, because not only can we demonstrate, so diclofenac is that NSAID, kind of like indomethacin. It's not used in the United States too much because it does have some liver toxicity, so we don't see it too often used here, but it is used presently in Europe. But with diclofenac, this is a picture of your villi in your intestinal wall, and that's what erosion looks like, and that's what a GI ulcer looks like if you were to cross-section. So you can see that the NSAIDs are causing ulcer, and not only did SEHI not cause that problem, but they're actually able to treat the ulcer caused by NSAIDs. And let's not forget that they're actually anti-inflammatory. That's part of what's happening, is that, and they actually are homeostatic towards the production of prostaglandins. So to get into the idea of, I'm sure you're all again are quite aware about the problems of what, and the former speaker actually spoke about too, is like, even in humans, you don't want to measure evoked responses when you have a neuropathic pain problem. So we deal with this in basic science as well, which is, how can we test an animal without pushing its paw and seeing how much it reacts? If it's not a pain that relates to, being pushed, right? It happens idiopathically, it happens spontaneously, or sometimes it's tonic. You're always in a state of pain. So one of the ways that we do this is we've borrowed from addiction research a rodent paradigm where we're going to train the animal to seek out something, but that what they're seeking out as a reward in this case is pain relief. So we have the animals that are in pain, we give them pain relief, and that's contextually related, so we give them cues. Where they're going to get pain relief is always in this corner with this furry carpet and this window. And then they learn to say, okay, so if I want pain relief, I'm going to go to that room in that corner with that furry carpet and that window. To give the breakdown on that. And so we train them in this paradigm so that the animal is free to choose where to go. And it's not dependent on, them being poked with a stick or a rigid tip, filament or anything like that. And it's whether or not, they've been associating the pain relief with the environment where they've received it. And so this is just an outline of what the test looks like. So the nice carpet in the window is not quite the way it looks, but we can constrict them to an environment where they can really see and feel the difference of where they are. And then the most important part of this test that I like to remind people is that when we test them later, they're not under the influence of the drug. So we test them before without any drug, before we get started, and later without any drug, because what happens is with drugs like gabapentin and morphine and things like that is that there's a drug-induced state of mental, change. And as they are on drug, they might act differently than when they're not on drug. So one of the, and when you're testing Paul withdrawals and those kind of tests that we saw earlier, you're always testing an animal that has a drug in its system. So if it has any of that change in behavior, it's hard to assess. So this is one of the strengths also. Not only can we do tonic pain, but we're looking at the animal's association with this without having it in them when we ask them, if you like. So when we look at that, and the way that we assess the response is that they're going to increase the time that they spend in the drug-paired chamber, where they got the relief. So in all of these scenarios, when you see the change in time, that means they spent all of their time where they got the pain-relieving drug. Okay. So when we did this, gabapentin had a good response actually for diabetic neuropathy. We put it in diabetic neuropathic mice, and we let them choose where to be once they had received their training, and they did seek out the gabapentin, as you can see. Forgive me. As you can see here. But what we also find is that they seek out the SEH inhibitor. In this case, it was an openly published compound, TUCB, but at 10 times lower dose. So we're seeing that we have really potent analgesia, and we're, as I mentioned formerly, we're not seeing the side effects that we see with gabapentin. So importantly, what we have to prove preclinically is that the drug's on board. So what we did was show, over the time of the training, of every day that we train them, we have enough compound on board where it's inhibiting the enzyme. And then also that we don't see any effect when we give that amount to an animal that doesn't have pain. So again, flat line means that we're not seeing that rewarding behavior in this paradigm that we would with an animal in pain. And just to show here that the target of inhibiting the SEH is really an important part about this. When we give we give the inhibitor to knockout mice. This is a mouse then that lacks the soluble epoxide hydrolase. We have this genetic mouse to use preclinically. And we say, okay, will it have any effect, if the target's there, if the target's not there, in a normal mouse, in a mouse without the enzyme present. And again, we just see no significant reaction to the inhibitors without pain present and no matter what type of mouse we use. And just to show that the mice are competent. So these knockout mice are able to respond to morphine just fine. Their reward system's intact. And this is also just to show, this is how the test is classically used, which is they're given morphine, they seek out the morphine. And this is just in a mouse without neuropathic pain, but also just the genetic knockout. Then to combine all of these ideas is to say that we have shown that the control mice don't respond, the SEH knockout mice do not respond, and that diabetic mice that have the target respond robustly to the SEH inhibitors. So these are all kind of the controls and all of the different ways that we have to demonstrate that we are targeting the SEH is responsible for the pain relief, and that we can see it in a number of different ways. And so as you've noticed over the course of this, I've demonstrated that we showed in diabetic neuropathy, we've shown it in a surgery model, we've shown it in rats, we've shown it in mice. So we take all of these steps to demonstrate, because people are, how do you really know, and what can you show, and how broad is it, and what is the spectrum of this? So that said, the other thing that we've done is demonstrate that it's actually also the molecule that we're using. So the EC5026 is the IND candidate, and that also If it just depends on the molecule, then it's it. And that's the effect. It produces the analgesia in the diabetic neuropathic mice. One of the unique stories that we have, it was an opportunity, is that we have a vet school at UC Davis, and we have collaborations with veterinarians. And one of them works with equine laminitis. So if some of you may know the story, but the horses stand on their toes. They have one toe, and it goes as a bone into their hoof. And then the lamina is the skin around that bone. And as it becomes inflamed due to hard training or diabetes, it can be diet-induced, that inflamed lamina will make it so that they can't stand. When they can't stand, they can't eat properly. When they lay down, they become hypertensive. And so you can see up there that in about 70% of equine laminitis cases, they're fatal. They need to be euthanized. Once the tissue destruction gets pretty bad, the neuropathic pain is horrible. The tissue destruction can get pretty bad, and as it continues, then they'll be euthanized. So when our collaborating veterinarian had one of these animals that was going to be euthanized, he got approval to use the SEH inhibitors as a compassionate use last try for this horse. And as you can see, 3 hours post-treatment, the horse was able to stand up. We continued the treatment, and we were giving it a super low dose of 0.1 mg per kg by IV, but this is a horse, so we ran out of drug by 5 days. Yeah, consider the kicks. But you know, Hula Hala is alive today. She lives at the vet school. She's used to teach veterinarians, and basically, getting into such a large order, you know, mammal means that we think that we're going to be translating this technology to human. And
is she still on the medication?
No, she's not.
Okay, thank you.
Okay. So yeah, that's a nice point to make, is that she's had no recurrent laminitis either. So it's important, there's several factors that go into recurring laminitis, making sure that the animal is not over exercised afterwards and things like that. But on a normal routine, some animals will per diet or genetics, but she did not. So tight diet control, kind of like human diabetes, tight diet control and not overtraining helps with that. As a specific indication for human diabetic neuropathic pain, but it is actually a wide spectrum. If we consider the research, it's a wide spectrum inflammatory and neuropathic pain treating compound. They're importantly inactive in the absence of pain, which I've tried to demonstrate. And that's one of the things that excites me the most. As I see people that want to be, you know, getting back out there, driving, you know, going, if they have to be at work, and getting on with their lives, and not having any off-target effects and not having any euphoria, you know, not having an addictive reward. Those kind of things are pretty important. And then we just love to get out and talk to people, because this is really a novel target. This would be a first-in-class drug. But that said, it's in a very well-known arm of biology, the arachidonic acid cascade. If you consider that, I think about 80% of all over-the-counter NSAIDs target cyclooxygenase, or target this pathway. I mean, it's a huge amount. But the novel nature of targeting the SEH to just elevate our natural endogenous lipid mediators is something different. And then we've, just to update you, gone through the preclinical toxicity testing. So I can report that we've done our 28-day, we've done one 28-day dog study. We're getting our 7-day rat study done. And those are, what is required by the FDA are 2 species and doing safety testing. And once we're all completed with that, then we go into phase 1 clinical trial, which is dosing in man. And we're hoping to get there by the end of this year, if not early next year, depending on the blueprint and their progress with us. That said, thank you.